Do we have too much government?
We need to put people ahead of corporate profits.
This system is so lopsided.
This threat is a real threat to democracy.
And I think that's really important. That's something we haven't been doing in this country for a long time.
Where do you start? What do you do? How do you do it?
Access to Democracy and other Eagan community television programming is supported by Thomson Reuters, makers of Westlawn Next and based in Eagan. Through Westlawn Next and other innovative online services, Thomson Reuters is the world's leading source of intelligent information for businesses and professionals. Online at thomsonreuters.com. And by U.S. Federal Credit Union, the member-owned financial institution offering service, value, and experience you can trust to the greater Twin Cities community.
Welcome. Access to Democracy is back. A first-time guest, and I'm really glad that we finally got Dr. Jimmy Levine from Minnesota Gastroenterology, which is hard to say,
right?
But one of the nation's leading specialists, and has been so acknowledged. You're from St. Louis Park originally, Harvard undergraduate, Yale Medical School, magna cum laude at Harvard, where all our presidents came from, but you went a different path.
Right.
And you were in Boston for a long period of time, associated, in fact, the New York Times did a large article about you in 2002 about your practice in Boston, but you came home. You came back to Minnesota. What compelled you to come back here?
Growing up, I'd always thought that I would move back. This always felt like home. I met my wife during medical school, and she's from St. Paul, and it was a natural move to come back.
Is she also a doctor?
No, she's an actuary by training.
Uh-huh. Well, that's interesting. And she's from St. Paul, so here you are.
Right, back in St. Paul.
Yeah. Why gastroenterology as a specialty?
People ask me that often, especially when they're about to have a colonoscopy, because they can't imagine why anybody would choose to do what I do. When I started medical school, my first week, I met Dr. Howard Spiro, who is a world-renowned gastroenterologist who recently died, and he became my mentor. And for 4 years, I worked with him, and he taught me a lot about medicine, the art of medicine and the practice of medicine. He was head of the Humanities in Medicine program at Yale, so he would always need me to help show up to see artists and authors, and so I got to see a lot besides just medicine.
And obviously it interested you.
Right. From my first day at Yale, I went to GI conferences along with him, so I think I developed an interest, and I had knowledge, so when I finally got to do different rotations, I had a familiarity. I liked it. He was a good role model, and it just seemed like the thing to do.
And you actually were involved in other aspects of the practice, though, internal medicine, and
right.
You really ran the gamut in your training days.
So before you specialize in gastroenterology or many other specialties, you do an internship and residency, and gastroenterology starts with a foundation in internal medicine.
And the fact of the matter is, when you were ready to leave Massachusetts to come back here, your patients were really vocal in opposition. You had developed such a loyal cadre of patients that they couldn't believe that you were going to leave them.
Well, I went from Boston to New Haven for medical school and then came directly here, so I didn't practice in Boston, actually.
Well, the New York Times article, where were you practicing at that time? 2002.
I'm not, there are two people in Minnesota who have the same name as me, and there's one at the Mayo Clinic who does a lot of exercise research, who's a pediatrician, and I'm not sure if that's...
No, this is you.
Okay.
This is
I
you.
never practiced in Boston.
I didn't. Oh, you didn't. Okay. But you have a technique, however, it's a little bit different from a lot of doctors, in that you'll come in, you'll sit down, you'll talk to the patient, things like that, that really relax somebody so much more than the doctor coming in and perhaps with a mask on, ready to operate or ready to do the colonoscopy. And it's so impersonal at a time when people are tense. Where did you learn that technique? And obviously it's something that's really important to the patient.
Medical school doesn't necessarily teach that, but you have mentors and people that you watch, so you, I think, try to pick up the things that work. Some of it is just your personality. Our group does take a lot of effort in mentoring and to make sure that people are at ease, and everything we can do to make the experience positive, we do. So people watch us at times, and we get feedback from staff and from patients, fill out questionnaires, so we really work hard so that everybody is having a good experience.
And certainly colonoscopy is not looked forward to as one of the most pleasant experiences that a person can have, although it has improved in the last 7 or 8 years.
Right.
In some respects, it's not quite as difficult on the patient.
Yeah, colonoscopy has a bad reputation, but almost everybody that has it says they can't believe that they worried about that, or I don't know why people are telling these stories. The preparation has gotten much easier. The main preparation we use is Miralax and Gatorade, which really doesn't taste bad at all. Obviously you have to go to the bathroom a lot. The examination...
Well, you have to empty out your system.
Right.
Yeah.
The examination usually takes about 20 minutes. People get sedation, and usually enough so that they're very comfortable. The medicine wears off fairly quickly, so the rest of the day it's not a bad experience.
And the fact of the matter is, what you're doing is using a scope with television on it as you're going through, what, 25 feet of intestine?
The small intestine is 20 to 25 feet, the colon is 5 feet, and we mostly look at the colon and sometimes the very end of the small intestine. So it's 5 feet that we're looking at very carefully.
And of course you can watch it on television and you can turn it into a game show if you want, but
Right.
no, most people don't. But you can experience it. Now, you have not been practicing medicine that long, not decades and decades, but you've been practicing it long enough to see how the practice of medicine has changed. What are your observations as to how medicine has changed?
When I started, almost everybody joined a private practice, and things are changing very quickly, and the majority of physicians now work for a health system. The big players in the Twin Cities are buying up private practice groups, and a lot of the specialists are becoming part of hospital systems and health plans also. So private practice is becoming difficult.
You don't see a lot of doctors with the neighborhood office anymore.
Right.
It's clinics and it's hospitals and clinics attached to hospitals. In effect, are you employees of the hospital or the health service?
So far our group is still private, but we have to have alliances with the different health systems and with the hospitals. And moving forward, the way of the future is an accountable care organization, so that people will get paid to bundle care. So you will get paid to take care of a whole group of people and probably not get paid to do individual procedures. So you need to find a way that you have primary care doctors, surgeons, specialists, the whole medical team.
All aligned with your group?
Or all partnering in some way, because we're going to get a bundled payment and it'll have to be split up, but the goal is to deliver high quality health care at a lower price.
Which is becoming very difficult today because of the intrusion of insurance companies into the healthcare industry. And I guess that's one of the things that has changed a lot since you started practicing, there seems to be more and more dependence on the insurance companies.
And more federal mandates. The electronic health record, so we have to have a paperless system really that includes labs, x-rays, procedures, patient notes, and we prescribe medications all electronically now, and that's mandated by the federal government.
Now, in a way, that's really good, because if somebody from Minnesota is in Utah or in France, they can really transmit all of their medical information electronically.
Yeah, it's easier and it's gonna be better. Right now, not all the health systems talk to each other. So if you stay within the health system, all of your records are easily accessible, whether you're in the emergency room, the operating room, your primary care doctor's office. But if you switch to a different system, right now the electronic medical records are not yet talking to each other.
Oh, so that's in the future.
That's in the future.
Where they really have to be able to have that capacity.
Right, and people will be judged or graded on patient outcomes, and all of that information is going to be collected electronically. So your electronic medical record is going to have to talk to who's ever judging what a quality medical exam is or what quality medical care is.
The only danger in that is if somebody from the outside can access your records without your knowledge, or without the knowledge, you know, if you're hacked, for instance, if there's hackers that come
Right.
into the system. And I guess that's a danger in everything that we do electronically today, not just medical.
Right, and so anybody in the health system could look at anybody else's records. There's obviously strict guidelines and patient confidentiality, and there's penalties if you do that, but there is that risk.
Now, what is solutions for healthcare?
Boy, that's a big topic. Clearly, we need to have health care that's accessible to everybody, and we need to make it affordable, which is really a big challenge. Part of the new health plan that President Obama has championed and is called the Obamacare is a step towards giving everybody health insurance. And hopefully that would allow people to get early treatment, preventable treatment, so they wouldn't have to use emergency rooms as primary care. They wouldn't have to go without medicine. They would get what they need to stay healthy, which in the long run should lower healthcare costs and make us healthier as a country. But if you have all those people who are now getting care, that's going to cost more money until we can get cost containment. And I think that's the next big challenge. Is how do we deliver quality care for less and get people healthier? Because so much of what we spend healthcare dollars on is because people are not exercising, they're overweight, they're not eating healthy, they're not taking personal responsibility.
And of course, we have so many uninsured people in this country, 47 million at last count that I heard. And when those people get sick, they go to an emergency room. When they go to an emergency room, somebody has to pay the hospital, the doctor, et cetera, for that service, and it's generally the other people who are insured.
Right.
So to me, single payer makes a lot more sense. I don't know what your opinion is on single payer. We've never discussed it.
Well, an advantage of a single payer system is that you would probably get paid faster because you wouldn't have to worry about sending bills to multiple different places, and there's less overhead. The government is very efficient that way. I guess the worry is if there's no competition and one person has control over medical devices and innovation, then that could stifle creativity.
But Medicaid really works very well with very low administrative cost. When we're dealing with insurance companies, we're talking about administrative costs that sometimes run 25–30%. We're seeing executives retire with golden parachutes, in one case $1.8 billion. Don't you think that that's money that should have gone into patient care, into research and development?
Well, absolutely. I think, right, having lower overhead means you have more money for preventative medicine, for paying medical costs, for medications. So as long as the extra money is plowed back into the system, I think that makes a lot of sense. If you keep lowering costs but don't put the money back in the system and you just save that money and use it for other sources, then it's not going to help
No,
medicine
that
in the
would
long
be pointless. We don't want money for medical services going into road building, for instance. But if we have that money and we have a unified single-payer structure, to me, as most of Europe has and a good part of the civilized world, they seem to have much better results and much better systems than we have here. We shouldn't be 20th in the world in deaths of newborn children, for instance. We should be number one because, in my mind, we have the best physicians in the world. We have the best facilities in the world. We have the best research in the world, although we've cut down on it markedly in the last few years for political reasons, which grieves me no end.
I think one issue that the United States is at a disadvantage for all those studies is that I think we have some more poverty and some more unhealthy lifestyle choices that are making our population have more problems with diabetes, heart attacks, other things. I think other places in Europe have a healthier lifestyle and have healthier people. I think they eat differently, they exercise more, they're lighter. So I think some of those factors go in, but we do have the best health care and we don't have to wait. Health care is not really rationed as it is in some places. So I think the United States does have great medical care, but it'd be nice for everybody to be able to take advantage of it.
So in some respects, our good living is also detrimental to our good health.
Right. And I think that's a huge public health problem that people are starting to address. There's a big push for having calories and nutritional information in restaurants, trying to limit supersized meals, trying to get people to exercise. That's really important because that's going to make everybody's quality of life better and greatly reduce medical costs.
And is it a fair statement that obesity leads to diabetes?
Oh, absolutely. That's a fact.
And diabetes is a burgeoning problem in the country right now.
A huge percentage of adults will or will become diabetic as the obesity epidemic continues.
I know my last physical, I was on a borderline, which I'm trying very hard to stay below. But just for that, I mean, I am 20 pounds lighter than I was probably 10 years ago. And I exercise today, which I didn't do for many years. So,
and insurance companies are building incentives to do that. They're paying premiums for joining a health club. They sometimes give discounts for different kinds of classes, and if you complete online education and you're motivated to exercise or change your diet, they're really trying hard to get people to be healthier.
Do you think having insurance companies in the healthcare business is a benefit or a detriment?
I think as long as it's done responsibly, I'm not sure that there needs to only be one payer. I think it's important to have limits on how much of a premium needs to be used for medical care, and it can't just be used as profit. But sometimes very innovative programs can come through with competition. So I don't think it's necessarily a bad thing to have more than one person involved.
Do you have to, in some instances, though, get permission from somebody in an insurance company before you can go ahead with a procedure?
I frequently have to do that for different kinds of therapies and for medications, and it's very frustrating to sit on hold for a long time. And
not only to sit on hold, but to me, many cases, in my experience, those people are not doctors.
Right.
So that you're calling somebody who's in an administrative position. I mean, if I take my car in for servicing, I don't want him to have to call Utah to speak to some other car service agency to get permission to go ahead when he sees what's wrong with my car. Now, that's a car. We're talking about medicine. We're talking about people's bodies and people's lives here.
Right.
That's got to be so frustrating.
Right. I think it's mostly done as cost containment. I'm not sure that it's done to try to promote better health. And so the people making the initial decisions are not doctors.
Which brings me back to my theory that we don't need insurance companies that are worried about the bottom line involved in healthcare. If we left it to the professionals, we would be much better off, in my estimation.
I think that's mostly true. I guess you need to be aware of costs when you're prescribing medications and you're ordering tests. And I think everybody could do a better job of trying to keep costs in mind.
And have some controls, yes, but but not necessarily third parties controlling the practice of medicine, which is really, we're talking about people's lives and people's health.
Right.
So where do you see this going?
For many years, we've been hearing about accountable care organizations and bundled care. It's happening very, very slowly. So I'm not sure if it's 5 years away, 10 years away, but I think that is the way of the future, where there's going to be protocols and plans so that from your primary care to your specialist to therapy, everything is going to be laid out for you, and there'll be an integrated system to send you from one place to another depending on what your needs are. And I think it'll be all controlled in different systems. So if you're not part of the system, and if you don't join a system, you're going to really be left out, and probably won't be able to stay totally private because you don't control patients. You need to be with primary care doctors and specialists.
But if we can cover everybody and people can't get turned away and they're in these systems, isn't that more beneficial to our society?
I think if we can deliver better care and get everybody health care, that's the goal that everybody would want. But it's going to be very hard to stay totally independent as a physician. You're going to have to align yourself with a health plan or become part of it. So physicians will lose some autonomy during the process.
How about all the physicians getting together and forming their own healthcare system and working and just setting some administrative people to control it to some degree, but having the physicians in charge, as they do in other countries, rather than an insurance company or some third-party entity?
Yeah,
would that work?
You know, I don't. I haven't given that a lot of thought, so I don't know. But
that's our next interview.
Right, but for payment, at least the way payment's going to be in the future, you're going to need to have physicians, a hospital, a clinic. You're going to electronic medical record. Everything's going to have to be integrated and together. So physicians would have to be owners of hospitals, and I think it would be tricky with the way things are now to do it that way.
Now, in addition to your practice, you do a lot of teaching. Is that correct?
I do some teaching at the hospitals that I'm in.
And you write articles. And you lecture.
I give talks mostly at the hospitals, continuing medical education talks. I've given a few other talks.
And you go to conferences.
Right.
Now, there's an article, I think you wrote it, Fecal hydrogen sulfide production in ulcerative colitis.
Right.
Yes. Oh, it was thrilling. I could hardly put it down. I couldn't wait to see who the bad guy was. But seriously, you do a lot of writing like that.
Right. That came during my fellowship. I was doing research trying to figure out a cause of ulcerative colitis. We know that bacteria in the colon play a role in it, and I was trying to figure out if people with ulcerative colitis had a different kind of bacteria in their colons, and that was the reason they got sick.
And did they?
They did.
I don't want to give away the ending, but...
No, they did, but we're trying to figure out, was that because they had the disease that their bacteria changed, or does a different kind of bacteria predispose you to the disease? But it's a very interesting question how all parts of the body are involved, and there's a large number of bacteria in your colon, and that people are just starting to pay more and more attention to. They're even looking at colon bacteria as a possible cause of diabetes. Sorry, not diabetes, obesity.
Really?
That different kinds of bacteria might cause you to absorb nutrition more, and you would gain extra calories.
So in addition to, and of course colitis is something else that you treat.
Right.
But in addition to just colonoscopies or sigmoidoscopies, which I don't know if they're as popular as they were a few years ago, you also specialize in other areas of digestive problems, right?
Right. So
For instance.
So my practice includes the esophagus, stomach, liver, gallbladder, pancreas, small intestine, and large intestine. So I take care of a variety of liver disease and a lot of problems with the esophagus, including reflux and some allergies, which are really becoming a very important problem, along with Crohn's disease and ulcerative colitis. So there's a mix of doing procedures and seeing people in clinic and doing long-term care.
Which do you enjoy more?
I like to have a variety. I wouldn't want to do just one. It's really nice to have both. And then also to go to the hospital and to see some emergency problems.
And you're married now, you have a family here?
Right, I have 3 children who are teenagers.
Oh, bless you. And you also have more hobbies than I can shake a stick at. You are a bicyclist.
Mm-hmm.
You are a water skier, is that correct? Or a skier, is it?
Cross-country skier.
Okay.
Yeah, I enjoy that a
Give
lot.
us some of the others.
I read a lot. I'm interested in genealogy, so I've been tracing my family tree, which has been a lot of fun.
I did that and a monkey fell out. I don't know.
I like traveling. I guess those are some of the main things that I do.
And you find time for that in addition to practicing?
Right, and with the family too.
How do you? Because I know that you are in the office early and you're out of the office late. Where do you find time for all this?
It's usually at night. Often when I'm home, I have to do some reading of journals, but I do get to spend a lot of time with my family or pursuing some of my other interests.
And I get the feeling that you're much more comfortable giving somebody a colonoscopy than you have been sitting here for a half an hour. Is that a fair statement?
No, this is fun. My first
Good.
time on TV.
Good, well, then let's do it again. And we've been talking with Dr. Jimmy Levine, who is a leading gastroenterologist and recognized as one of the top physicians in his specialty in the nation, and a very pleasant individual who will sit down and talk to you before he probes your innards and relaxes you and makes you as comfortable as possible. And we'll see where the medical profession is going and how we can improve it, and people like you go a long way to doing that. I thank you so much.
Well, thank you for having me today. It's been a lot of fun.